Thank you so much for the invitation to be here today. It's really my privilege to be here. It's great to see people in 3D and not just on Zoom, and in this wonderful setting. My disclosures. So I just wanted to say a couple words about Bob to start with. I first met Bob in, I think, 2011. I had just I'd spent many years in the industry and I was transitioning from industry to academia. And this was at the very first QIN meeting that I had gone to. And one of the postdocs in our group was actually a PhD student of his from before, from Arizona, and she introduced me to him. And he was an amazing mentor and had been very, very influential in terms of the way I thought and my research direction. And we've heard from everyone in terms of his research breadth and depth, and his mentorship. But the other thing I wanted to also talk about was actually his being a sponsor and advocate. So even for people who he was not directly mentoring in terms of his students or his postdocs, but people who were whose success he really had not that much. That was not that vested in. He was, again, enormously helpful and would speak for them when they were not there. So he would talk about, sort of promote them and push them forward and sort of push them to think about themselves as leaders and taking on leadership roles. And I really cannot appreciate that enough. So, and all I can hope is that in some small part, I can continue to pay forward what he did for me over the years. So. This study is a little different in terms of what we're doing here. It's a study I'm really, really passionate about. This is work we're doing with the NCI intramural. It's a cervical cancer screening. The goal of the study is to actually screen 100,000 women over the next 2 years in low and middle income countries, mostly in Africa and South America and in parts of Asia. The part that we are working on is the AI part of this study. And so I was going to talk about the study and some of the things we've learned in doing AI for the last decade. I've been working in radiology, of course, and oncology, but also in ophthalmology. And one of the things that keeps striking me is that the problems are the same. No matter where we look, we run up against the same kind of issues. And there's a lot of lessons that we've learned doing this over the last decade that we are hoping to put into practice as we start to scale up. From my experience, this is probably the thing that's probably the closest to a patient, where we might, although the AI part of it is not going to be directly affecting the patient during phase 1, the goal is to see how well it does sort of in the background. And if it works well enough in phase 2, we'll actually present the output of that to the clinicians. But the ability to do something at that scale and see if it works is pretty powerful, pretty scary in a sense, actually, frankly. So the cervical cancer is a big problem, especially in low and middle income countries. It's much less of a problem in places like the US, where between vaccines and good care, it's really not a huge issue. The goal, this is the WHO goals for what we want to do in terms of vaccination, screening, and treatment. 90% of the deaths today for cervical cancer patients occur in low and middle income countries. So it's very much a problem in that sort of setting. So this is the sort of moonshot initiative. It's based on 2 aspects of it. One is self-sampling and HPV typing. So most cervical cancer is precipitated by HPV infections, and there are multiple subtypes of HPV that have high and low risk. So the step 1 is to have the self-sampled HPV typing, and then we have image acquisition on a low-cost device. That low-cost device could be an Android camera. It could be some kind of a couple different options there. And it's going to be followed with treatment if necessary. And so this entire sort of pipeline of what risk-based management is the goal of the study, again, led by some very eminent epidemiologists from NCI. So as we've heard, it's getting pretty easy when you have lots and lots of data to create algorithms. We see this all the time. You put your data in, you put your annotations out, something pops out. We have high school students coming up with AUCs of 0.95. It looks wonderful on paper. And actually, it works wonderful in the setting that they ran it on. And this is an example of a study where, again, they had taken the same sort of data set and found an AUC of 0.91. Everyone was very excited about it and was ready to sort of deploy it. Then the question came as to, when you start to put it out in the real world, you suddenly see that the performance that you were so excited about internally doesn't necessarily translate elsewhere. So these algorithms tend to be brittle. You don't necessarily have good sense of uncertainty. They're not self-aware. They don't tell you when they don't know what, they don't often tell you if they're unsure, they're not fair, they may be biased. So there's a lot of different things that can go wrong with these algorithms. And this same group actually followed up with a paper not that long ago saying, okay, we had that first publication that said everything was great, but then when we looked into it further, we ran up against all these kinds of issues. And so some of the issues that I wanted to touch upon very briefly are these 7 that I've listed here. And again, the reason I'm bringing these up is because these are the things that we were considering as we're training an algorithm for sort of real world deployment. The first one that shocked many people is that these models are not repeatable. We've heard about the robustness issue. What we hope is if you take the same person and image them twice, which we don't tend to do obviously with CTs and stuff like that, but in cases where we can, and you measure them twice, you should get the same answer twice, both times. And that seems to be sort of the fundamental requirement of a biomarker, that it has to give you the same answer twice. It should transfer across devices. I'll go through this in a second. But this was example, the cervix of the same person taken twice. In one time it said the probability of disease was 0.01, called it normal. The next time it said it was 0.98, it was precancer. And to the human eye, they look almost the same. If you plotted the test-retest probability, so if you, on one axis is the first test, the second axis is the retest, you see this, it should be along the diagonal, and then you see this flip-flopping. And if it look like a Bland-Altman type plot, you'll see right around the middle, it does this behavior that is undesired. This is not unique to cervical cancer. We saw the same sort of issues with all kinds of things, whether we're talking about knee osteoarthritis or eye disease or other things. What we do see is if you do something like Monte Carlo approaches. So we do Monte Carlo dropout, get 40 models, 20 models, and get the mean of those models. Then you get much, much better test-retest performance. And you can see that as the along the diagonal, it's so much better when you do that. So the ability to get a tight test-retest performance is something that we find to be extremely important. And we've found this approach to be quite good. The second issue is we've seen this over and over again, they don't generalize. There's a lot of different reasons for that. Here's from the cervical cancer situation. You train and test on data set 1, you get 0.9. You train and test on the other one, you get 0.86. But if you train on one and test on the other, you get essentially random. If you have it all together, you get a good model. But this is so concerning, is that if you don't know that the population that you're going to be running your data on, and you don't have a good out of distribution detection, you don't know that it may not work. So this is something that one has to be concerned about. This is actually a really interesting research area, and we are hoping that somebody in the audience is going to help us solve this. But certainly increasing data diversity, multi-institutional data sets, federated learning, a lot of different things there. The third issue is that real world is not binary. There are many things that lie on a spectrum, but we treat everything as black and white. This is human input. So we take the same images and ask a bunch of clinicians to annotate it in a 3-class level. And you can see some people have mostly reds and some people have mostly greens. And this is consistent across domains. We saw that in ophthalmology, we saw that in COVID, we see that in cervical cancer. People tend to have their own internal cut points of where things are between normal and abnormal, or between mild and moderate, or moderate and severe. Everybody has a slightly different cut point. And you see this when you plot different people on an ROC curve, that some people tend to be more specific and some people tend to be more sensitive. So one way that we have been thinking about it is, instead of just putting everything as a binary, come up with a continuous score of severity or risk. And that seems to do a much better job than, because of the way the cost function is set up in terms of pushing things to ends, it has this very sharp defining boundary between disease and no disease. And so if you're right near this boundary, it can really flip-flop a lot. So, but coming up with a more number of classes or a sort of a scale, we found it much to perform better. In the cervical cancer scale, we found adding an equivocal class greatly reduced the misclassifications. So instead of calling normal as severe or cancer or cancerous none, having this what we called a gray zone allowed all of the things where the model was uncertain to go into that gray zone that could be looked at in much more detail. Another problem is that models may fail silently. And we've seen this over and over again. I forgot who had this nice violent plot of dice scores. You'll see that most of the dice scores might be 0.8 and up, but there's this long tail of failures. And we don't know which ones they are unless somebody's looking at them. And if somebody's looking at them, then we don't necessarily need them, maybe. So the question is, how do you identify without ground truth, which are the cases where the model failed at? And again, these methods such as Bayesian approaches might come up with uncertainty estimates that are well calibrated and can identify the cases where somebody has to look at it at least with more carefully. So that then related to that is that the models are poorly calibrated. And so the one thing that we don't see often enough in our publications is calibration curves. And we really need to look at the performance of all of these models on a calibration curve to see how well they perform. And again, what we found is that these Monte Carlo approaches helped us build much more better calibrated models. We talked about overfitting, radiomics or deep learning doesn't matter. We see a lot of publications with over-optimistic performance, and we really need to be very, very, very careful as a community, as reviewers, as other grant reviewers, as paper reviewers, in considering that. So lots of, essentially comes down to good statistical rigor and data hygiene and separating your test data, and Marilyn talked about it as well. But another one is black boxes, and many of these methods are considered, especially deep learning methods. People like to use things like saliency maps, but really those are suspect. So I think we need to be very, very careful about how we use, and these are a couple different papers, one from just this year about the false hope of these approaches. And actually, when we have a paper on looking at saliency maps and looking at a framework of seeing how well they work or not. So potentially we might think about creating more explainable models inherently. So instead of just saying, is this cancer or not, we might want to say where it is, draw bounding boxes, that way at least there's some spatial localization, we might draw segmentation. So there are things that we might do that might improve the explainability as opposed to just saying yes or no. The question of bias and fairness comes up a lot. So obviously, this is something that we're all quite concerned about, and especially in healthcare. The surprising thing was this work from Judy and others that showed that just looking at a chest X-ray, you can tell what someone's self-reported race is, which is sort of mind-boggling. How on earth does a chest X-ray know what your self-reported race is? And what does that mean? When you're using such an algorithm downstream on a task that a human cannot do, so this kind of a superhuman task, how do you know that you're deploying it in a safe way? What does it mean when the algorithm can do something so extraordinarily well, but there's no human way to put oversight on it, right? Normally we talk about using AI in a way that can be used in conjunction with the human, where the human can supervise it. But if it's a task that the human cannot do, what does that even mean? We've talked about the lack of diversity of the data sets, and certainly MIDRIC and efforts like that to improve the diversity are great. We've seen phenomenal superhuman capabilities in terms of whether you're using your fundus photographs to prevent who's going to end up with Alzheimer's in 5 years from now, or breast cancer risk or whatever. But when you have such human capability and the risk of bias and a lack of fairness, one has to be really, really vigilant about how one uses these algorithms in the clinic. So when you're going to deploy it, I think there's a ton of things we need to think about. Is it the correct image? Is there quality is good? Is there blur? And thinking about repeatability, this gray zone issue. And now we have this wonderful algorithm, but it's not real time. what we want to do in the real world is actually have it in real time. So how do we think about taking this very complex model that's actually 40 different models and make it run in almost real time? So this is our overall strategy in terms of genotyping, followed by risk prediction to have high risk, low risk, intermediate risk. And it seems like it does much better than having this combination compared to one thing alone. So I'd like to sort of conclude with this checklist of things that we've been thinking about as we go from taking something that was a paper in the lab to something that's actually going to be run on 100,000 women in the real world. And so there are things like repeatability, reproducibility, out of distribution, calibration. Does it make grade errors? Is it confidently wrong? Very often it's confidently wrong. How do you train models that are not confidently wrong? Do you assess quality? Does the image even, you feed in a picture of a cat and it'll happily tell you it's got cervical cancer or not. But how do you know that it's a right kind of image? Should it be adapted locally? We've talked a lot about this. Should we have a single global universal model that works everywhere, but is not perfect? Or should we have fine-tuned models like your phone? Your phone knows your voice really well. Do you need a local model for every institution? So what is the plan to monitor it, especially for a task that you cannot do as a human? So lots of things to think about. And